All right. Hi, everyone. Thank you for staying connected and joining us. Such interesting conversations, and I'm really hoping that we can kind of dive right in to some of the questions that have been pouring through from our audience members. And of course, I have some curiosities myself I'd like to toss in there. So for the first one, I would like to ask Dr. Tapia, regarding your presentations, we've talked a lot about opportunities for digital health that have been presented through the pandemic in terms of capturing public attention on digital health technologies with telemedicine and things that we've been advocating for such a long time. Do you see specific challenges that the COVID-19 pandemic or potentially any pandemic may present to the use or expansion of digital health?
Yes, I think that there's huge challenges. One of the elements that not only digital health, but any, let's say, serious approach for the preparedness of future pandemics, and I would say for the new normal of any health system would be to consider the quality of the information. What Dr.Shonchoy has mentioned is based in really to have the information on time, reliable, and that has really a good coverage. And I think that's a first challenge. I think we have to see seriously the quality and the infrastructure and that countries have, that the health system has, and also the capacity for the health system to have the concept of different stratified levels of information. I think we have to go really down to the, let's say, to the last mile process of what's happening. And I think that's what digital health provides, the feasibility to go really to the last mile interaction between the health provider, the health systems. If we're looking at vaccination, if we're looking at the health record, primary healthcare units, I think they need to be connected. They need to be seen as networks, and that's the basis for digital health. So I would suggest that the first thing is that the second challenge is resistance for the use of information. Remember that one of the elements that digital health provides is transparency. Even though we know that it's very important for any politician to have information, they also see information as a risk. And if that information comes online, that comes without any filter, that comes as it is, it's also a resistance from the political side, from, let's call it, from the technical side, from the responsibility of health authorities, professionals, academics. I think we need to really pursue the agenda to make the issue around transparency and the quality of that information. And my third challenge is investment in the terms of really putting money and to open the concept of investing in public health. Dr. Shah Monday conference mentioned the importance of investing in public health, investing in laboratory networks, investing in human resources. But at the same time, I would add to what he said on the first day, sorry, it wasn't Monday, it was first day, is the importance of human resources. So we need to have a comprehensive review and to use the importance of investing in public health in general, which includes digital health. And also, I would agree and take a few seconds more, is I think we have the lead in the multilateral organizations, WHO, PAHO in our region, have already sent out the signal that we have to really pursue digital health. And I think I'm a true believer that they can be really the leaders in encouraging that process, working together with governments.
for, and it's, really important that we are able to identify and address those challenges early. Dr. Shonchoy, I'd like to ask you the same question. When we're talking about the index that you and Dr. Ahmed have developed, do you anticipate any challenges and how we might overcome those? I'm thinking of maybe some political, perhaps need for more resiliency there. But in what your experience, can you talk to us about what it would look like to implement this index more globally?
Sure. Thank you, Dr. Rusk, for this question. So I see there are two parts in your question. Like one is like what are the challenges we face when we were doing this study, like in terms of data, and another one is implementation wise, like how governments would take it favorably or how they will implement it. So let me answer the first question, which is for our index, what is most important is the daily recovery data. Now, daily recovery data is really a technical issue, because how you consider something as a daily recovery, because those who are going into the hospital will be, that's our primary source of the data, that hospital release data for the COVID patients. But we know from different sources that in the low and middle income countries, many people are not going to the hospital for COVID cases, right? So for a large chunk of patients are taking treatment at home. And there are two parts of this fact. One fact is the hospitals are not equipped enough to handle such a large surge of COVID cases. Another one is a large distrust on the publicly provided healthcare services. Like, so many people to handle it. So people are taking this risk and treated at home. Now, what it creates is we only get a partial data. We only get hospital release data, but we don't know how it infected and I just recently got out of COVID. We don't have that data. So one biggest challenge for this index is having that really nuanced and high level daily recovery data, and that is essential. That is really essential, and we struggled a lot to get that data. So that also I'm kind of mimicking what Professor Tapia has mentioned, that low middle income countries still lacks this kind of high quality and very high frequency data. They don't have that system, or they don't have the reporting framework where we can feed all this data on a real-time basis, so that anybody, like, it doesn't require that much of a technical skill. Anybody from the developed world can design an index and help them to have policy decisions. Now, the second part is like the political will of government to have this kind of, zone-specific
now my microphone
lockdown.
is
on.
Okay, let's leave it like that.
Oh, sorry. It sounds like Dr. Saleh is trying to get connected.
Right.
Please continue.
Okay, so the political willingness of the government to kind of adopt this kind of policies. So I tell you very frankly, we also wanted to do it for American states, like in different states whether we can do it, and we are in Florida, and like one example is Florida does not provide this daily recovery data, so they denied not to give us. So our index essentially will not work if we don't see daily recovery data. So it perfectly fits within the, if the government is willing to, admit that there are COVID cases and we need to do something about it, they need to upfront and release this data as honestly as possible, as diligently as possible. And that is like the political will of the government to tackle it combinedly, communitively, like everybody is coming together to tackle it. And then economists, public health experts, scholars, everybody can aid their brain and their expertise to create a solution for this. But if governments are large denial mood, that not to accept or not to release data, then we are handicapped. We can't do anything about it. So I think it needs to be a combination of both. Like, we need high quality data, political willingness, and transparency to tackle this.
Yeah, I thank you for those comments, and I'm encouraged at the research that you both have done, but also not discouraged, but a bit put out really that, Hans Rosling many years ago has been advocating for more transparency in data and available and open source data. And this conversation's been going on for so long. And I know a lot of us feel like we're pushing a rock uphill where that is concerned. So I'm quite hopeful that if there is ever anything to be gained from this pandemic, that maybe politicians and decision makers and data owners might wake up a bit and recognize the importance of making that data available. Because obviously we're all struggling to make these kinds of decisions and to make sure that they're evidence-based. So thank you for that. I do want to notify our audience real briefly because Dr. Shadi Saleh has finally managed to join us. We are so grateful that you are able to be here with us. And so we are going to extend this part of the panel a little bit. So if you're looking at your agenda and the times aren't lining up right, we're going to buy ourselves just a few more minutes. If you will indulge us, I'd like to give Dr. Saleh about 5 minutes. I'm so sorry that we can't do your full presentation right now, but I'm very interested in the work that you are planning to present on the use of iCloud electronic health records in refugee and displaced populations. And if you could give us just a brief overview of that work. Again, I apologize for cramming you into such a short amount of time, but please, if you would take a few minutes and just give us an overview. We would love to include those questions in the panel, as we have already received some from the audience who have read your Lancet paper.
Perfect. Thank you so much, Andy. I'll try to make that shorter than 5 minutes. So just do a story around what we're doing, even without the slides. So basically, just to give a little bit of a background, there are approximately 60 million refugees around the world, and 1/3 of those refugees, 1 million refugees, are in this region. When we say this region, we mean the Middle East and North Africa region. So that's approximately 1/3. The problem with those refugees starts with the migration journey, when they leave their house and move throughout different places to the sort of the host country, or the country that will be willing and able to host them. And during that migration journey, health obviously is a major concern, because a significant portion of those who do that migration journey tend to be children and women and people who may be elderly. And all of those three groups, they have specific health needs, whether it is non-communicable diseases, women's health issues, or children health issues. So the question is, what happens when one of those 20 million, they have a health problem or reach a country where they need to seek care? The challenge there has so many aspects or facets, one of which is not having access to the health information, their own health information. Secondly, the whole issue of context, including language. Thirdly, the issue of wanting to selectively share information so that they're not at risk. So in all of this creates quite a bit of a challenging setting for both the health seeker, who is already a vulnerable individual, being a refugee, and also the host health system, which is supposed to provide healthcare for those individuals. So here comes digital health as a solution for this. And the idea that we came up with, because we were living firsthand that experience with our country, Lebanon, having approximately half of its population as refugees, is to use digital health to try to address this. And the answer was a concept that we developed that we called Sijilli. And Sijilli in Arabic means my record, in this case, my health record. And in summary, what we did is we created mobile electronic health records for refugees, so that they would securely have access to their information wherever they end up in the world. It's saved on the cloud. It's secure because it has a two-stage verification process similar to what we use on our phones. The information that is included in Sigilli is basic health information, and it's linked also to a website. So basically, from an operational standpoint, wherever the refugee ends up in the world, if they started from Syria, if they started from Libya, from Yemen, from Colombia, from Venezuela, it would only be enough to say one word, that is Sigilli. And the healthcare provider can Google that term, and from there on, it's there through their passcode. So this is a practical use of digital health for a major global health problem, which is refugees. And so far, we have provided that to 10,000 refugees as phase 1, and now we are moving to phase 2 with 100,000 refugees. The thing perhaps that is also relevant to the topic and the audience of this conference, be it the Americas, is that we have been receiving inquiries from a couple of countries, and specifically in, of course, in South America, to see if this is something that can be implemented there. And the answer is yes, it can. We already have a proof of concept. 10,000 refugees already can end up anywhere in the world and have secure access to their health records, which is, as important as anything in one's life. So this is my 3 to 5 minutes summary, Andrea. I hope that I didn't take so much time. It's always interesting when talking about digital health to face technical problems.
That is
That's
true,
right.
and the irony is not lost on us, I'm afraid. Thank you for that overview, and I do have some audience questions for you, but before we get to that, I'd like to ask Dr. Ahmed a question about his work. I know that we were discussing right at the end of the presentation how this index could be applicable in both high income as well as resource limited settings. And I was wondering if you could speak briefly, and we do only have just a few more minutes left to the panel, so I want to make sure everybody has a chance to respond to some questions. But if you could speak briefly about how you see that disparity and what challenges you think or what differences there might be in applying this index in a high resourced area versus a resource limited area.
High resource area, you all know it, the data quality is much better. And in the middle and low income countries, the data quality is not that great. No matter what, I think we took only few parameters, not a lot of parameters, only 4 or 5 parameters can be used. And if the commitment from the health system is possible, as we talked about, that transparency, and if it is there, I think it's easily possible to put together and apply for low-income countries too. Because we were doing before just by luck, is we have to do it after Ramadan or Easter and make up some stuff. But now you have an evidence and how it works. And it is not only evidence just created in a simulation, it is a real evidence based on the successful countries. So that would guide us in future pandemic and other places and how we could really handle it. Because now this is a time to prepare for next one. You're muted.
Yes, thank you so much. Speaking of technical issues, we're going to put user error on top of the list. Thank you for that, Dr. Ahmed. I appreciate it. And Dr. Saleh, there was a question that came in from our audience actually yesterday, really around capacity building and whether you've encountered any capacity or training issues in using electronic health records in fragile settings, and if there's a capacity building opportunity to expand their use, or what your thoughts are around the absorption and use of these technologies.
So first of all, I think that in reality, if we're talking about low and middle income countries, the entry point for any population-based intervention should be a low cost, low capacity building needs approach. So everyone now has a smartphone. You go to the middle of Africa, and everybody has a connection. I do not know how, but everybody has a connection. They have a smartphone. So definitely the natural entry point is a low tech, simple idea that goes into that smartphone. So this is when we're approaching population-based interventions. When we're talking at the level of what Dr. Roberto and colleagues from FIU were talking, some of that discussion is more of a systems angle. And this is where you need more technologically advanced capacity building, evidence-based policy making. And this is where it becomes a little bit more expensive in terms of capacity building and infrastructure. So for us, at least for the Sigilli example, it's more of a population-based angle. It's it's low cost, contextualized. Everybody has the ability to understand what's going on. And actually, most of our field work was done by volunteer students in healthcare, health sciences disciplines, nurses, medical students, public health students. So, and it was really easy for them to grasp the concept and move forward with it.
That's very encouraging to hear. I think the use of these technologies is so important, and I think their utility has been sufficiently demonstrated in this panel today and in others before it. So that's encouraging. I have a regional question that I would like to put to both Dr. Tapia and Dr. Saleh. So given the fact that there are so many populations within resource limited settings and others that have been suffering from economic disparity even before the pandemic, and that the pandemic has increased this economic crisis in these poor countries, the WHO and PAHO have been making an effort to reach areas where technological resources are scarce. What do you see as the new vision and strategy developing within health programs to assist those areas that need to be targeted for increase in technological resource and access? For Dr. Tapia.
Dr. Tapia.
My apologies.
Well, I think it's a tough question in terms of how to really address that. I would like to take what Dr. Saleh mentioned. I think he's totally right in the concept that any digital health, let's say, initiative needs to think about the importance of reducing disparities, to really think that it has to be, let's say, your first population to be served are those that are out of the box, those that have difficulties in really accessing this type of technology. And I totally agree. And we have also made a lot of efforts to really make sure that those that are in most vulnerable condition, and as Dr. Saleh mentioned, they already have a phone. It's amazing. They have economic problems, disparities, and they have a phone. And it's amazing how can they really engage into this if it's very simple, and even it's better if there's no cost for them at some point, because it cannot be considered an impact in their economy. So I think they can be engaged. And in that way, you have a greater opportunity that they would be, let's say, pushing from bottom up in terms of the importance of their participation. Their voice can be heard. We have seen a lot of these initiatives around the product a lot around the economic part, in terms of agriculture, in terms of providing information for pricing and things like that. But in health, I think we have been a bit behind, and there's the opportunity. So yes, I think that there's an opportunity. We can do that, and we have to. But that's why I think that we can build on the leadership that multilateral organizations have to really look into this and to be those that push or that motivate governments and institutions, NGOs. A lot of these initiatives come from NGOs, come from those that are there in the presence, in the field, and those are the ones that see the problems, and they find solutions. At least they have alternatives for those solutions. And I think that we need to have a space for them. I really think that NGOs in different parts of the world are really the ones that are making these initiatives, and that are really, together with academics also, but governments are a bit behind. So let's try to make this concept of having alliance and to really align energy so that we can really benefit. I think those in high income countries, they are already included. I think we have to consider digital health as a way to include those that are outside right now of benefiting of any health intervention.
Yeah, I think I would agree with that, and I think many of us listening today would as well. Dr. Saleh, what is your perspective on that topic, given your experience in the Middle East and the Northern African region? Does that hold, or are there additional pieces that you would like to add to that?
So I will start off with what Dr. Tapia started off by saying, that the question is a little bit complicated, and I will try to answer as much as I understood of it. Basically, in all honesty, I think that digital health may be the most profound transformative change that can happen in healthcare for vulnerable population and population who are underserved. I mean, there's no question about it. And the entry point is easy. And basically it's this, it's the smartphone that everyone now has, where they have their WhatsApp, where they have now their Facebook.
I think we may have lost his audio. Okay, I'm going to give him a moment to come back on while we are waiting for Dr. Saleh to get reconnected. My closing question for everyone on the panel, if you could take 60 seconds, I know it's brief. We'll start with Dr. Shonchoy about your closing comments. Oh, Dr. Saleh, have you rejoined us?
I did, yeah.
Yes, okay, great. Go ahead and wrap up your comments.
So I think this would be a concluding remark, because I know that we're running short on time. I think digital health is the most significant transformative change that can happen in healthcare. The entry point from a micro standpoint is definitely smartphones. And then it's much more complicated from a systems perspective. I wish, Andria, that policymakers, and I heard what you said, I wish policymakers are driven by evidence as much as we would like as academicians. Unfortunately, I think all 5 of us have had experiences in one way, shape, or another with policymakers. And we know that almost all of them are driven by politics more than evidence, unfortunately. But we can never give up on trying to change that.
I think those are admirable sentiments that I certainly echo. Given Dr. Saleh's tone that he has set now as we're moving towards closing comments, Dr. Shonchoy, I'd like to move to you with your final thoughts for today.
Thank you, Andrea. First of all, I would like to thank you all for inviting me. I mean, I'm not at all qualified to be present here because I'm an economist, not a public health expert. So, first of all, thank you very much. So, I would just put the sentiment that Dr. Saleh said, but in a different way, which is we need much more investment in the health and capacity building for poor countries. When we look into the data, we will see that a large chunk of money invested on other activities, but not given priorities like health and education. So health sector needs to get its fair share for investment, and we need data. I think this is one thing that needs to be like at the forefront of any policy conversation. That we need data, we need data, we need data, and as soon as this gets into the head of the policymakers, into their deaf ear, that we need data, we need quality data, and we need capacity building so that we get real data on time. That will be the solution for the next pandemic or any of these disasters that is coming ahead of us. Thank you.
Thank you for that. Dr. Ahmed, your closing thoughts.
Well, my closing thought would be, if we could really come into the picture with the policymakers saying that, is it possible to change? I know there is a lot of resistance, a lot of different mission and their ideas of election and pleasing other parties. But I think the data would be the key to any change. Data would be the key to decision making. If that can be communicated enough, I think that would be great help. And I agree with Dr. Saleh, and it has been proven over and over again in Bangladesh and many other places. The poorest of the poor, the ladies, the women, can change their livelihood by using smartphone and all of the stuff. And same with Dr. Shonchoy's work in our city randomized control trial, how it can be used for elderly people to receive the retirement benefit without going through all the hassle. And with that, I think data is the key to this.
Thank you. And Dr. Tapia, I move to you.
Well, thank you. This has been fantastic, and I just want to say a few words, and I agree with Dr. Saleh what has been mentioned here. I think we can really take seriously digital health as the way, the strategy, to really make a transformation in health systems. Health systems need to really look into more than the systemic part is the reason that they exist, and those are people, the environment, the concept of really looking and putting people at the center of any process. And I think that's a real transformation. And to make sure that the concept of universal coverage needs to be real, and the only path that I can foresee is going to have two things. One, build up the power of individuals within the system, and second, to really encourage that the system looks in the vulnerable and those that are in less conditions, and to be included using digital health. So in summary, I agree, digital health is the way to really make a profound systems transformation.
I would agree with that as well. I want to thank each of you for your participation today, for your time today. I know Dr. Saleh, it is quite late in the evening in Beirut. I appreciate your extending your workday to be with us. Dr. Shonchoy and Ahmed in Miami, Dr. Tapia in Mexico. As you were mentioning the very final pieces with this emphasis on the need to get a hold of our policymakers, try to change the system from within. I want to speak now to the students and the educators that are listening, that are online and engaging in these conversations, that really the future is yours. And if you follow these fields of study and get engaged in the political system, having been trained in evidence-based research and in translational research and the importance of digital health and moving forward, you have an opportunity to enter these systems and to make these changes yourself. So I encourage all of our young people listening to grab a hold of that mantle and wield it responsibly. Thank you everyone for joining us. We are going to be moving now to the closing remarks for the Global Health Conferences of the Americas 2020. So I'm very happy to yield the digital floor to my colleague, Dr. Becerra. Thank you so much.